Hello everyone, Bob Tauber here again, and I want to welcome you all to week 2 of online psychopathology. And in week 1 we introduced something called the biopsychosocial model of mental disorders. And now we're going to start kind of deconstructing that into its various components. And the focus for week 2, a strong focus, is on the assessment of symptoms, knowing their names and knowing how to assess severity or the dimension of symptoms, because it turns out, as I'm sure all of you know based on your own experiences, that whatever the symptom is that you might have, whether it's related to emotional health or or mental health or physical health, they tend to have dimensions. Even if you've hurt your leg, and you're recovering from a hamstring injury in your leg, there are times when it's completely preoccupying and it hurts constantly. It has a tremendous amount of frequency during the day and duration, and it's really impairing your functioning. And then as it's healing, that severity starts to diminish. It becomes less impairing, less preoccupying, and you become it lasts for a much shorter time. So that's the focus this week, on symptoms and looking at how they also have this severity type dimension. So I've gone ahead and written a lot of what we're going to cover, including a real quick review of last week's. So right behind me here, hopefully I'm not out of the frame here because I don't have a lot of space to work with. But here the focus is going to be on symptoms, and that's pulled out of this large biopsychosocial model. So in review real quickly, the biopsychosocial model says that a person experiences symptoms of mental distress, mental ill health, and symptoms are abbreviated, let me just remind you, by SX, symptoms. And those symptoms tend to have factors that make them better or worse, or cause them initially. And those factors are called etiologies, and we abbreviate that ET. And those etiologies often are in the domains of biological domains. Again, for a depressed mood, a lot of times it could be a genetic predisposition, but it could also be too little dopamine or too little serotonin, the monoamines. And also there are psychological or temperamental domains of things that cause symptoms, and psychological for, again, a depressed mood can be retroflected anger turned inward on the self, negative thinking patterns, which comes to play when you study cognitive behavioral therapy, or social environmental etiologies of symptoms. And these are really true social factors, like the depressed mood is because you simply have no opportunity to get out of your funk, so to speak, given your social circumstance, whether that is the family system you're in or whether that is in the environment where there's no opportunity to accomplish goals that you'd like to accomplish, educational work goals, or whether poverty issues fit under social, various isms, racism, sexism, ageism, those type of things. So anyways, etiology creates symptoms in this biopsychosocial model. And then symptoms, I'm going to shift over here now. There you go. Symptoms, based on how they present, and they tend to present as patterns of symptoms quite often for people who we see in counseling. Symptoms fold into various diagnoses based on their presentation. You could take 6 of the same symptoms, and if 4 of the 6 present, it could be one diagnosis, and if 3 different ones or 3 others present, it could be another diagnosis. And this right here is the area of the Diagnostic and Statistical Manual. Diagnoses, again, DX. The DSM-5 is the rule book for converting symptom patterns into diagnosis. And then finally in this model, we have treatments, which are the treatments are working on are based on our understanding it works best for various diagnoses and or their symptoms. And those treatments also tend to be biological, psychological, or social, environmental, Again, often based on your experience and your education or your personal preference, or perhaps what's worked for you if you yourself when you've gone in for treatment. So treatments are often abbreviated TX. Now, a point I think is really important to make is that we don't, as counselors, licensed professional counselors, MFTs, clinical social workers, or psychologists, we don't just treat diagnoses and their symptoms and at this level. We also treat etiologies. In fact, most of our work is about working back on this side here with what I call the issues. The issues a person comes in with. And I just want you to know that the DSM, even though its focus is on mental disorders, which are patterns of symptoms that are severe enough to cause clinically significant distress or impairment in important areas of functioning, what I sometimes think of as D&D, disability and distress. The DSM also has a section that covers issues. Those are not considered mental disorders. They're more along the line of significant problems in living. But I want to show you where that is in the DSM. So pardon me as I step out for a second. In the DSM-5, I think that's about right. If we go to page 715, and you should go look at 715 if you can, in the DSM, you will see the beginning of a section that says, pardon for my delay, I keep missing the page by one. There we go. Okay, so I think this is probably visible. Other conditions that might be the focus of clinical attention. And in these 15, 20 pages of conditions, there you have problems related to family upbringing. And there's a whole array of codes for problems that are related to families and family systems, and problems related to primary support group, and problems related to child maltreatment and neglect problems, child physical abuse, sexual abuse. Again, you may diagnose somebody who abuses children as having pedophilia, and that is a mental disorder in the DSM. But you may be treating the client that the fact they were victimized with child sexual physical abuse is not a disorder, but it is a focus of treatment. So those are in the DSM starting on 715: child sexual abuse, child psychological abuse, neglect issues, again, a lot of family system issues, but also things like if you're treating educational problems or occupational problems. So it's very important that you be aware that there is a section in the DSM for these other areas that we're calling issues, which are sort of often, go along with the symptoms. And you can, in fact, when you write up a diagnosis, add these codes, because these actually do have codes and names as well. But these are not actual formal mental disorders. So you want to give that a look, page 715. So let me get back to this model. So breaking out one portion of this model, because in the future weeks we'll be starting to look at how symptoms form various diagnoses, and we'll be more focused on the diagnoses. When we look at symptoms, it's a very important thing to know is that symptoms have names and symptoms have dimension. For the purposes I had mentioned in our week number 1, we'll really most mental health work only focuses on an array of 20 to 30 common symptoms. Things I've already mentioned, like depressed mood and anxiety, or high mood like mania, or symptoms of eating disorders or sexual disorders, or substance-related symptoms, or personality disorder-related symptoms. But the fact is that, like all good professions, we have a ton of jargon. So there actually are at least probably 500 symptoms that have been named in mental health and in psychiatry. And just in case you want to impress folks that you've seen some of those symptoms, I've included in your resource section a document which is called Signs and Symptoms of Mental Illness. It says typical signs and symptoms of psychiatric illness. And it starts with an actual many pages of an index. And the index lists the names in alphabetical order of the various signs and symptoms. And these are just the A's. And then it'll tell you where you could find an actual description of that particular symptom. And just really quickly going down some of the symptoms of the A's: abstract thinking, acrophobia, affect, aggression, agitation, agnosia, agoraphobia, alexithymia. I don't know what that is. I don't know what several of these are. But what you could do is look up, and they're divided by areas of functioning, like, for example, thinking versus feeling type symptoms, and get a description. So in your resource section, this document is there, and I think it's also really interesting to look at. But again, for the purposes of psychopathology and the DSM, many of these do appear. I just noticed depersonalization, and dementia is also in the DSM, but many of these you won't hear about in the Diagnostic and Statistical Manual of Mental Disorders. But please do give them a look so you realize that there's really a breadth of names for symptoms. But what we're going to focus on in the next segment of this tape is more on the dimension of symptoms and beginning to look at how to assess symptom severity. So that's the end of part 1. Thank you.